in attendance. If you have questions as we go along, feel free to use the little question Q&A thing, and someone on our panelist panel here will attempt to answer them. If we do need to have more in-depth discussion about a question and we end up going a little early, we could maybe do a Q&A at the end, but we'll see just how much time we have. So let's get this show on the road. Hello, I'm Sean, and I'm the N3C training coordinator guy, and I have helped coordinate these wonderful people to tell us about the new Medicaid data that is available in N3C via the PPRL Privacy Preserving Record Linkage program. So I'm going to hand it off to Tom Richards from Johns Hopkins, and he's going to give a little bit of an overview of Medicaid data in general and how it compares to EHR data. Take it away, Tom.
Okay, yeah. Okay, thanks, Sean. Let me share my screen here. Okay. Okay, hi everyone. So I'm Tom Richards. I'm with Johns Hopkins University in a research group. I've been in public health research for a long time. I've done a lot of work with claims in general, both Medicare, Medicaid, and commercial insurance. And for the last 15 years or so with EHR data, mainly Epic, there's some other EHRs as well, and linking claims and EHR data when it's available, and we're able to do that. So I wanted to talk a little bit, and I'm going to talk fast because we have a lot to cover, 4 or 5 presenters. So I wanted to start a little bit about CMS. I'm assuming that there are people on the call who may be new to claims data in general, and specifically to CMS. CMS administers both the Medicare and the Medicaid programs in the United States, and Medicare is primarily for 65 and older, but there are enrollees in Medicare. You can get Medicare for some other reasons, like certain disabilities and stage renal disease. So there are about 65 million people as of the end of 2022 who are in the Medicare program. The Medicare claims were loaded into N3C back in November, I think it was. So they're there, and if you've worked with those, you'll be familiar already with claims. Medicaid is the other program that CMS administers, and it's kind of split into Medicaid, the Medicaid program that is primarily for lower income people and families, and then there's a separate children's health insurance program, or CHIP program, that's for children whose families make too much money to qualify for Medicaid, and so it's an insurance program for them. Medicaid is a joint combined program that's between the federal government and states, and each state has their own eligibility requirements. So to get into the CHIP program in Maryland, the requirements might be different than to get into the CHIP program in Florida. The claims, though, have the same structure. So that's not so important. Those differences aren't so important for what we're going to talk about today. But as a researcher, they might be important to you to understand denominators, who's in, who's not, why somebody's not in. And it's complex because, like I said, each state has its own set of requirements, and all of them, in addition to age, they all have some sort of poverty level or family income level threshold to qualify you for Medicaid. And you can see the numbers here. Medicaid had about 86 million enrolled as of January, end of January, and 7 million additional nationally children in the CHIP programs. And of that 93 million total, about 42 million are children. So the Medicaid data fills in a huge missing piece that you don't get with the Medicare data, primarily the children 18 and under. CMS has been around for a long time. It's another takeaway from this. So there's a lot of data, and the CMS website, which I give a link to later, has a huge amount of information, and you can find out everything you want to know more about Medicare, Medicaid, and the data. So if you haven't worked with claims before, a claim is basically a billing record. It's an invoice from a provider or a facility, an institution, to an insurance company, in this case, to CMS for Medicaid services. Some of the highlights of the claims are that a patient may come to your EHR or come to you and have their information in your HR, so you know what was done to that patient at your facility. The claims to the insurance company reflect everywhere that the patient had services, so you get a much more complete view of the patient's health record from claims. But claims are limited in what they have. Again, it's a billing record, so what's on a claim is what's important for reimbursement. Claims use fixed data standards and vocabularies. I think with OMOP, a lot of that's been resolved anyway with the OMOP vocabularies, but there are standard procedure code sets, ICD-10 diagnoses, and for prescription drugs, they use a national drug code or an NDC code. They contain death dates under certain circumstances when somebody dies in a facility. So you may not know that in your EHR data, but if you get a claim from some other organization and it has a death date on it, then you'll know that. They are billing records, so there are charges and payments on them. I don't think those have been loaded yet into N3C, but that's one of the benefits of claims. And then they're also accompanied by enrollment files. So patients sign up for insurance and they stay on for a certain amount of time, and then they might drop off. For commercial insurances, it might be that somebody changed jobs, so they now have a new insurance. For Medicaid, people, I mentioned before that there's an income requirement, and it's been really somewhat controversial. A big problem with Medicaid that there's what's called churn. There's a high churn rate for Medicaid enrollees because most of the Medicaid recipients are non-disabled adults who are working, and they tend to work in jobs where income fluctuates, and they tend to work multiple jobs, multiple part-time jobs. So they might pick up another part-time job during a holiday season or during tourist, something related to tourism during the summer or something like that. And so their income fluctuates and might go up temporarily. And many states, most states, do review of enrollment requirements regularly. And if somebody's income goes up and the state reviews their enrollment, they might not be qualified for Medicare anymore. And the state will notify the enrollee. And usually there's not a lot of time. I've seen examples where the states notify people and they have 10 days to resolve the issue. So that's not much time. And so what tends to happen is with Medicaid enrollees, they go on and off Medicaid a lot. And that's a problem. It's not good for anybody. There's administrative costs for the states associated with enrolling and disenrolling people. And there's plenty of research that's shown that when there's a discontinuity of care like that, or an obstacle to care, patients don't get they may not get preventive care, and then they may end up in a hospital for something that's a preventable condition. There's worse medication adherence. When they go off in insurance or change insurance, they may have need to get a new provider. So all of those things contribute to worse health outcomes. So it's not very good. What's interesting with the Medicaid data is that for the last couple of years now with the pandemic, there was legislation that required the states to not do that, to enroll people for 12 months. So there wasn't such a big churn. Now that the pandemic is over, we're starting to see people getting kicked off Medicaid. And then Kaiser did a lot of work, and I think they showed that most of the people who disenroll from Medicaid re-enroll within a year, and a lot of them re-enroll within 6 months. So I think there's potential now with Medicaid data to do some work. I mean, we had 2 years or so where people weren't kicked off to really see if that made a difference. But anyway, those are some things about Medicaid in particular that are different from Medicare and commercial insurances. So comparing claims to EHR, I think I mentioned, that EHR contains the data that from the patient's services at that facility or that doctor's office. The EHR contains orders, and prescriptions. So there are things that the physician said the patient should have done. If the patient doesn't get it done or doesn't fill that prescription at that facility, then you may not know it. The claims, if they go somewhere else to have a lab test or fill their prescription, the claims will reflect that. So you'll have that in the claim. You'll have information in the claims that you won't have in the EHR. Something right here. So I mentioned before that the claims don't have the depth that the EHR have. Their billing records. What's important to the insurance company is that a patient had a hemoglobin A1C test, for example. What's not so important to the insurance company is what the result of that test was. So there's a procedure code that's submitted to the insurance company, but not the result of the lab test. And you do get that information in the EHR. What the claims may not have also are things that providers don't or tend to undercode. So there are certain things, and in particular with kids, so in the Medicaid data, this would be a bigger issue. Providers are careful about coding certain things that might lower self-esteem of a patient or maybe result in down the road in higher insurance premiums or things like that. So obesity is a good example. It's really undercoded. So there are diagnosis codes for it, but you might not see those on the claim. But if you have access in the EHR to anthropometric stuff, height, weight, BMI, and lab test results, then you can determine at least the propensity that someone would have to certain diseases. So a benefit of the EHR over the claims. The EHR, the claims may contain things that aren't in the EHR because they're billing records. Providers fill out information in the EHR, but it essentially goes through then a billing department. The billing department and the organization want to maximize the reimbursement. And so billing teams will try to do that and many times use software to help optimize the claim and maximize the reimbursement. And so that's called upcoding. And so there may be diagnosis codes get altered slightly, or modifiers are put on procedure codes that might not be in the EHR, but they will be on claims. So some differences in claims in EHR. The data's been transformed into OMOP, and I think Stephanie will talk, or others will talk more about this. I mentioned with Medicaid, there are two sort of major types of claims that come from an institution, like a hospital, and or claims that come from individual or group practices, and those are called professional claims. The data, claims data also includes an enrollment file, which is very important. It's something that an EHR doesn't have really. So patient comes to see you, they're in your EHR. If they don't come back for a year, you don't really know, did they not come back because they're healthy, or because they went somewhere else, or because they didn't have insurance. Claims in the enrollment file tell you when a person was enrolled in Medicaid, and for how long and why. And then so you'll know, for example, if someone, and in Medicaid, I mentioned there's a high churn rate, so you'll see patients in the enrollment file who are on for 3 months, off for a couple months, back on for 3 months. And that's important information. You can use that to do calculations and to analyze things like cost or utilization. There are also people who are eligible for both Medicaid and Medicare. They're called dually eligible or dually enrolled. That's important because if someone is dually enrolled and you're working with the Medicare data, then you know you don't have everything. You need Medicaid as well, and vice versa. And the enrollment file can also be used to make a distinction between non-users and non-eligible people. So, you know, like I said before, if somebody doesn't come in for a year and you see on the enrollment file that they're not eligible, then that's why they weren't in the Medicaid data. If they were eligible, but there are no claims, then it might mean that they were healthy. Let me pick up the pace here a little bit. Claims in general have a header and a list of services. The header has stuff on it that applies to the entire claim. And then the list of services are the list of things like diagnosis and procedure codes. It's a lot, I was thinking it's earlier, it's a lot like a receipt from a store. You go to Walmart or Target, and on the receipt, there's some stuff at the top, the date, maybe the store name and location. The bottom, if you paid maybe with a credit card, they might have your name, part of your credit card. That's like the header information that applies to the whole receipt. And then on the receipt, you have the list of the things that you bought. It might have a code, an item number, a description of the item, a quantity, and a cost. The claims are a lot like that. So you can think of them in a way like that. It's a bill with a list of things that the person had done. There are two main standard claims. They're paper. I think some places still use paper billing, but institutions use what's called the UBO4 claim form, and doctors and individual physicians use what's called the CMS 1500. This is a picture of what they look like. It's hard to see in the slide here, but you know, you can get a sense that, or you can see that there's a section up top here that's header information that applies to everything, and then there are various places where you list things. These lines here list procedures or revenue codes that the patient had performed and costs. So that's what the paper form looks like. The claims are an electronic representation of this form. And that's been transformed into OMOP. Some challenges with doing that, and Stephanie did the work, did a great job, and she can talk more about about the transformation, but challenges are trying to take that form and translate it into the OMOP common data model. And then there are patients who are coming from multiple sites. The claim ID or Medicaid ID links patients and from within Medicaid. So it's a way to link across sites, but you have to map that to the EHR IDs. Date shifting, I don't think is an issue anymore, so I'm not going to really talk about that. And then when you're working with EHR and claims data, there are always discrepancies between the two. I'll talk maybe a little bit later about why that's the case. But trying to match claims from the EHR is a challenge. And then claims, again, are billing invoices. They're not visits or hospital stays necessarily. If somebody is in the hospital for a long time, and there are cases, particularly here at Hopkins, I mean, we have people who are in the hospital for a year or more. Hopkins isn't going to sit around and wait to get paid for that, so they'll submit interim bills. So there may be a bunch of claims for one hospital stay. So that is a challenge when you're working with the claims to take all of those and link them together. Otherwise, you end up overcounting things. Here are some sites, some links at CMS. I mentioned there. It's a good source of information, you know, so once you get there, you'll see that you can find out about Medicare as well there. And so I'll wind up here. Just, you know, as a final thought, remember again that they're bills. So if they're for CMS to make payment to providers. So money's involved. If it's important to get paid, then it's going to be accurate and on the claim, and you can trust it almost as a gold standard, sometimes even more so than the EHR. And the things that are important for reimbursement are the date of service, who the provider saw, and the procedures that they had done, and the diagnosis codes. So those are things that are important on both institutional and professional claims. So that's it. I'll stop here and turn it over. I think Stephanie may be up next.
Can you all hear me okay?
I can.
Yes.
Do you see my screen? Am I sharing?
Yes.
Okay, great. So I'm Stephanie from Hopkins. Today, I'll talk a little bit about how we transform Medicaid data set to OMOP. So we've been working on various different PPRL linked data set to N3C COVID data. And now we have CMS, both Medicare and Medicaid. And I think next we will also have imaging data soon. But we have social determinants of health, viral variant data, mortality, as well as the N3C COVID. And N3C clinical coming soon. So CMS Medicaid claims data came to us through Acumen. So the source claims files that we have is Acumen derived. And in Medicaid data set, we have the inpatient claims, other service claims, long-term care claims, as well as the prescription claims. So we took all the beneficiary that are present in all the claim source files, found all of the codes that are present in those claim files, and we translated all the codes into the OMOP concepts and transformed them in and inserted into the respective OMOP domain tables. The person data came from the DE-based beneficiary summary file. It contains patient demographics and enrollment information. It came from 53 distinct state codes, and data spreads from 2017 and 2020. We are working to get later years, but there's some delay currently. But we hope to get data more recent, further out than 2020. The IP is the inpatient facility service claims data. The OT contains billing information related to outpatient facility. LT claim file is for the long-term care facility services, and RX contains the billing information for prescription claims. So this is just a overall overview of how the data is transformed. We took all the person information from the beneficiary summary file, and from all of the claims source data, we took the provider and the billing provider information, as well as the begin and end date of each of the claims. And we translated all the code that exists in the claims files and translate into OMOP concepts. And based on the domain ID, we inserted the data into the respective OMOP domain tables. In the person table, there's people with birth years spreading from 1910 to 2020. First, there were people with more than one gender and multiple birthdays. And since we do not know which one is the correct one, we had to omit them. And OMOP only provides one place to hold the location. We did build a location history of the people, person found in the data, but we had to pick the latest one from that data to add that reference with the person table. There were also multiple race and ethnicity value found in the data. So we had to pick one, and the most days, enrollment days, were chosen for those values. These are the spread of the age that are found in the data set, and we may have to clip people with age greater than 90 so that it's not identifiable. It currently we didn't clip it, but we may have to in the future. So because these are claims but not really visit, we had to pick respective dates that are found in the claims to figure out or construct the visit occurrence construct. So in the IP, we chose admission and discharge date. And if the claims contain reference to emergency room, then it would have a ER-IP visit designation. Otherwise, it will just be inpatient visit. From the long-term care, similarly, if it had reference to a hospital, then it will have inpatient visit type. Or if it has reference to home health, then it would have an outpatient visit type. Otherwise, it's a non-hospital long-term care visit. From the outpatient claim files, also, if there's a reference to an emergency room within the revenue center code, then we would use a ER visit as a visit type. Otherwise, defaults to outpatient visit. And for from the prescription claims, we use the pharmacy visit type. So we looked at all the columns where the codes are present in the respective code system. And so in IP, we have IC10CM, IC10PCS, 6PICS code, or CPT4 or NDC. On other services claims, we found there were IC10CM codes, IC10PCS codes, HCPCS codes, or CPT4. Both IP and OT file had a respective code system column. So we referenced those to figure out which, how to map those codes that are present. There were also some codes that are null, where their code system was not defined. And we consulted with Acumen, and they said if it's null and it's coming from OT, we should default to HCPCS. And if it was, the code system is null, but the code is coming from IP claims, then we should default to IC10PCS. So that's what we did. So the long-term care, it was just IC10CM codes, and prescription claims just had the NDC codes. So link there is, that's all this information is summarized on our GitHub page. So when we translated all the code and the terminology that are found, we took all of the values that exist in the claims file, created a crosswalk table to translate those codes into OMOP concept IDs. There were ethnicity code that are values were also found in the same column where the race value was provided. So we had to figure out how to map that properly. There was a multiracial concept of code that are present. And in OMOP, there wasn't a standard concept ID that tells us that it's a multiracial race. So we did choose the non-standard code to map those values. So observation period spent from 2017 to 2020. And we generated a code map crosswalk table to take all of the codes that are present in the source file for our transformation pipeline. So the OMOP target domain that we generated are observation, condition occurrence, procedure occurrence, drug, device, and measurement. The measurement table will not contain any of the result for the test, but if the test was performed and there was a presence of those data in the claim file, then we did generate those measurements, but those will not contain any results for those tests that are performed. Some of the analysis consideration you might want to reference location. When we build a location table, we added the state code and zip code. We didn't add the county code, but we will do that in the upcoming builds. In the condition status concept ID and condition status source value will contain the proper order position of where the diagnosis code came from in the claims, and the condition status concept ID will contain the proper OMOP concept for admitting versus primary versus secondary diagnosis concept IDs. In the procedure occurrence table, there wasn't a comparable column to hold the procedure status concept ID or procedure status source value field in the CDM So we actually created those two additional columns to hold the order of the procedures that were present in the original claim file, so that you could find out what order of those procedure codes were in the claims. So if it was in the first position, you will see 1 in the procedure status concept ID field. And if the procedure code came in, was the second column, then you'll see 2 in the procedure status concept ID. So the couple things that we didn't get to include in the current build is that if the drug was administered inpatient versus if the drug was found from the prescription claims, we should have specified the drug type appropriately to indicate whether it was a administered drug versus prescription, a prescribed drug. But currently it just has a claim type of 32810, and we hope to update that with more granular information in the upcoming build. Currently our visit occurrences is defined so that all these different overlapping or embedded time for the same patient found coming in from multiple claim files all get separate visit. Begin to hope to roll up all those embedded or overlapping visit or 1 day difference of the visit into one, so that we could construct more coherent visit occurrence dates. So that's all for me. I think Assad is going next. I think.
We have Tom up for another couple of slides. Tom, in the interest of saving time, do you think we could skip the slides about the patient ID mapping and the date stuff, because we have some links that we can share at the end that talks about those things?
Yeah,
too.
yeah, I think that's a good idea. And also, there's been a lot of work on those things, and so some may not even apply anymore. Okay. Okay, so one of the, I'm going to talk just for a couple minutes here about using the claims and the EHR together. I don't want to spend much time on this, because I think you're already used to it from using the Enclave, that patients have different IDs from different sites. Now we have another source of data, the claims data. Claims data is a way of linking all sites that a patient went to together. I mean, you have the complete record of everywhere the patient went. But I think to a large extent that's been done already in N3C. I don't know. It was the case that sites had to agree to participate, and if they didn't agree to participate, then their Medicaid and Medicare data wasn't linked. I'm not sure what the status is of that right now, but Sean or somebody else can talk about it. I actually mentioned a lot of these things earlier, but some of the ones that I didn't talk about, when you go to link EHR and claims data, it seems like if there's a service today on the claim and you look in the EHR, then that service should be there for today. That's the ideal case. Unfortunately, it doesn't work that way. You always find claims, and you look in the EHR and you can't find the matching service. Sometimes it's there, but it's off by a day. There are different reasons I think that happens. There are many dates in the EHR: appointment dates, service dates, billing dates, dates of onset of a disease or diagnosis. On the claim, it's really just supposed to be the service date that gets submitted or the admission and discharge dates. Places may wait and bill like the day after somebody gets discharged, or maybe somebody comes back or checks in or something. I don't know exactly all the reasons why there are discrepancies and things are off by a day. But when you're trying to link the claims in the EHR together or match claims to EHR, you may need to do some things like use a window around the dates to do the matching. I mentioned about organizations not waiting for long lengths of stay and submitting interim claims. I mentioned about billing departments doing upcoding earlier. Yeah, so I think, and I mentioned about providers being reluctant to code certain things. So those are some reasons why claims in EHR won't exactly match up. So I did want to mention this piece because this is common with claims, particularly with inpatient claims. So what I'm showing here is an example. The first three arrows up at the top here are three different claims that got submitted to Medicaid in this case for a person and an inpatient stay. And you can see that those claims have overlapping dates. Some of those reasons might be that one I mentioned about facilities submitting interim claims. Some may be that when a patient's in a hospital, there may be bills coming in from different places. The hospital may submit a bill. An attending provider may do their own billing and may submit a bill out of their office. Sometimes that doesn't show up even in the inpatient claims file. It shows up in the professional claims file with a place of service that indicates that the service was done in a hospital. So the point is you have multiple claims here. And then there's even a fourth claim, this fourth arrow, claim D, that starts on the last day of this first group of claims. And so when you're working with this data, what you might do is put all of this together on this sort of green colored line, that fifth arrow down there, and put all that together and consider it one inpatient stay from December 20th to January 23rd. And there are some things you can look at on the claim that would tell you whether that claim day is really part of that stay or not. And if it's not, you might have this last case on the bottom here where it's actually two different stays. But the point is that you're going to find multiple records for what we would call a visit or a hospital stay. And so that's something that you're going to have to deal with in this data in OMOP. I think there's some work in building in N3C, they're calling them macro visits, in putting this all together and making it easier to use this data. There are some things I mentioned that you can use to help resolve that. I think I also mentioned about enrollment data and what it gives you earlier. So here's sort of a list of what you can do with it. And there are some numbers here at the bottom where I talked about churn rates. There's a higher number of Medicaid users who sort of drop out of Medicaid compared to commercial. So this is saying 38% of Medicaid users do not re-enroll. So they drop out. And then, like I said, Kaiser showed that they do re-enroll like 6 months later or a year later. And I think I talked about most of that. Pharmacy claims, they give you a lot more important information than you can get in the EHR. So the EHR for pharmacy is sort of the intent. It's what the provider prescribed for a patient. the claims tell you that the patient actually went and filled that prescription and got that drug. And they tell you exactly what the drug was through the National Drug Code, the NDC code. The quantity and days supply are also there that were dispensed. And you can use that information to produce some metrics and some things that are important for pharmacy analysis and pharmacy research and medication adherence. So pharmacy claims are very useful additional data to EHR. And then I'll stop here and just remind everyone again, just keep in mind, if it's important for reimbursement, then it's going to be on the claim and of high quality. So that's it, Sean. I'll turn it back to you. Or Assad, whoever's up next.
It is me indeed. So let me pull up my thingamajigger. I'm not going to talk a whole lot. I do just want to mention a couple of brief things here. One is that these data are brought into N3C as part of the Privacy Preserving Record Linkage effort, which is a very cool cryptographic technique that is used to link data about individuals from different data sources without knowing any personally identifiable information about them. And as Tom mentioned earlier, this is something that individual data partners that are providing our EHR data opt into. So I will talk a little bit about seeing how you can tell which data partners have opted in. And it does create some interesting things with regards to having multiple identifiers for patients that you may need to work with in order to align EHR data and the CMS data. Rather than going into that right now, I will mention that we have office hours on Tuesdays and Thursdays, and on Thursdays are our CMS office hours. So that's when it's best to ask questions about the CMS data. And we have in our N3C training portal, we have a training module all about PPRL. We've done a number of different trainings at this point, and we have some documentation in there. And so I just want to show you guys how to get to that so that you can go and check it out. If you start at the N3C homepage and you were to click on the training material button, you would land on the page that describes the various training materials that we have in N3C, one of which is our training portal, which describes a number of N3C specific training modules. And if you search for PPRL, one of those training modules is around PPRL, this privacy preserving record linkage, which is how we are pulling together all of this information from different data sources. Within this training module, there are lists to different resources. They're actually kind of in not any particular order. I should fix that up, but we have sort of an overview of PPRL and how it works, which you can check out there, and I recommend that you do. We have a guide on the CMS data, which is still being having details added to it. And we previously ran a webinar just like this, but for the Medicare CMS data back in December. So you can find that via the YouTube link here. And then a few weeks ago, we did a seminar on deduplicating patients because they do and can have different identifiers at different sites. And the information from the CMS or other PPRL data can actually be used to identify which IDs refer to the same patient. But there's some caveats to doing that, and we covered what those are in that webinar. So that's all I'll say for that. In the interest of time, I'm going to pass it on to Saad.
Great, thank you, Sean. I will share my screen. I do see a question about SDOH data on the Q&A. I can answer that hopefully towards the end of the presentation, and we'll send you some resources. So can you all see my screen?
Yes, I can hear it.
One second. Okay, so I wanted to talk about 4 things. where to find it, just more practically, where to find the CMS claims data, Medicaid and Medicare, just as a reminder, what it looks like, how to request access for it, and how to load it in your analysis. So if you log into the N3C Enclave, this is the homepage. It has a various links to different applications. One of them, and one of the most useful and important ones, is the data catalog. So if you go to the data catalog, this is collections of data sets that are available for researchers if they have approved access for it. So you can see the more general EHR OMOP data in LDS or the de-identified data security tier. So for people who have worked in N3C before, they are familiar with those. We have made the CMS, Medicare and Medicaid collections available also in this data catalog. So if you go to the data catalog, and then for Medicaid, you would go to this collection center for Medicare and Medicaid services, Medicaid data sets. And so these are claims data sets, but in the OMOP format. So it's exactly the same name as the EHR OMOP table. So you will see a person table for demographics. You would see a condition occurrence table for the list of conditions, a procedure table, etc. if you're familiar with OMOP. And same thing for Medicare. Another way to get to the same data sets is so either they're here, or if you want to get to look at all the PPRL related data sets, so all the data sets that are not EHR but got linked to EHR via PPRL, you can go to this data collection. And here you can see we have mortality tables coming from various sources. We have viral variant tables, but we also have a folder for Medicare and a folder for Medicaid. Now, for what the data looks like, I'm going to show two things. I can't show real data, so I'm only showing the header here. This is just going back to Medicaid. I'm opening here the person table. And so it looks exactly like an OMOP table with a person ID, a data partner ID, which in this case is just Medicaid, and then various information about demographics. If you want to know, so important thing here, a person ID here is the CMS person ID. And so it's unique for each person coming from CMS. It has a CMS prefix appended to it. If you want to join this table with the EHR, in the data collection, there is a CMS mapping table. This gives you the mapping between the CMS person ID and the N3C person ID or OMOP person ID. So I've opened the CMS mapping table in a contour. I didn't want to show the real IDs, but I just wanted to show the column names. So for this table, you have the CMS person ID, which is the person ID that you will find in this Medicaid table, for instance. And then the N3C person ID, which is the person ID that you will find in the regular OMOP person table. So that's how you would perform your join. Another thing that Sean mentioned is that only only a number of sites have opted in to link their data to CMS claims, were both Medicare and Medicaid. And so if you want to know which sites did that linkage, because the numbers that Stephanie showed are larger than the numbers that you actually will have access to, simply because not all sites allowed us to link their data to claims yet. So if you go back again to the data catalog, which again is available from the homepage, and if you go to either the LDS or the de-identified data collection, the manifest table has 2 columns. And let me open it in a contour here, just so I don't show the real tables. And I'll go quick because I see that I have 2 minutes left, but you have a column called CMS linkage. And so this column is basically telling you whether a site opted in to link to CMS claims or not. And so you can look at the site, you can filter by that column and then look at the corresponding CMS data partner ID. So 19 sites out of the total almost 80 have opted in so far to link to CMS. Now, lastly, how do you apply for access? So if you, from the homepage, if you are creating a new project, or if you're requesting a creation of a new project, in the DUR form, which let me just go back to the homepage real quick. So in the homepage, there is a data use request form that you can fill in to request the creation of a new project. That project has to be a limited data set, and so you have to provide an IRB. And when it's a limited data set request, you can request access to CMS. Now, when you request access to CMS, it gives you access to both Medicare and Medicaid data. You can also, if you have existing projects, you can, I'm going to the, you can go to the My Projects dashboard and then request to upgrade your project to include CMS data sets. And so I don't have anything on my dashboard because I'm not part of research projects, but there is a link to revise a DUR, which takes you to this form. And here you can request access to CMS and upgrade your project. If you've already have access to CMS data in your project, before it was Medicare, now you can also import Medicaid data sets. And then lastly, how to import that data sets into an analysis. So if you have a code workbook, for example, I'm just creating it in an example project, you can go to the data catalog from here and then import those data sets in your analysis. So if you go here, you go to data catalog, you go to Medicaid, and then here you can import the data sets and start working with them in your project. I'm not sure if I missed anything, but I'll stop here because we're at time and see if there are any questions.
Thank you, Saad. I will note that there was one question in the Q&A that we might want to record here for the recording. Are there claims from durable medical equipment files from Medicare and Medicaid also available and mapped to these data sets? And Stephanie notes that we did not receive the DME claims information from Medicaid, but it were sourced from Medicare. And those made it into the table, Stephanie?
Yep.
Cool. All right, well, we're at the top of the hour. I think we can hang around for a couple more minutes for folks who have the availability to do that and want to ask further questions. But aside from that, we'll call this, and thank you everyone for stopping by.
Sorry, for people who are still here and for the recording, a couple of quick announcements. What we released are the claims transformed into OMOP, both Medicare and Medicaid. Very soon, probably next week or the week after, we will also have the claims in their raw format, just for people who prefer that format to analyze claims. So there are people who are more familiar with OMOP and others who are more familiar with claims. So we'll have the option to use either one, and it will be on the same location in the data catalog. So that's the first announcement. The second one is something we released about a couple of weeks ago, which is a patient deduplication capability. So we have a global ID in the person table that tells you, for example, if a patient from 2 different sites is actually the same patient. And we've published, we have a training, something on the training module about that and some recordings, but feel free to send us, reach out to us if you have questions about that. I just wanted to remind people of that.
Thanks, Saad. There's a question in the Q&A. Will histology information, for example, ICD-03, be included in this transformation from CMS to N3C? Stephanie or Tom, do you know, happen to know that one offhand?
So if the code system is IC10 CM or IC10 PCS, they're included. But if it's ICD-03, I'm not sure those are mapped. I don't think they're mapped. And I'm not sure if the claims will include ICD-03 code system.
How does the IDs work if a patient is eligible for both Medicare and Medicaid? Does CMS have a single identifier for a patient with those two different IDs? That's a good question.
I think the PPRL will identify them as the same person.
Yeah, I think the question is, in the CMS mapping table, are there separate mappings for Medicare and Medicaid, or are they sort of like all together in the mapping?
Sad, I think we produce one for Medicare and one for Medicaid. Is that correct?
That is, I mean, we're using the bid ID. So if it's the same at the source, then the CMS ID will be the same. I'm not sure if it's the same. I can check, but in any case, you'll be able to use the N3C person ID to tell that it's the same patient. But that's a good question. We can check and get back to you. But I'm not sure if the CMS identifier would be the same. We'll have to check the source. But if it's not, you'll be able to look at the N3C person ID and say that it's the same patient.
So CMS person ID will not be the same because they're coming from two different source claim files. But through the PPRL linkage, you should be able to identify the same person.
They should also have the same global ID, which we just added recently. If a person has a match in the CMS data, that person will have a global person ID. So that's another way to perform your linkage.
All right. Well, I think we got everything. Thanks everyone for stopping by. Thank you, Tom and Saad and Stephanie, for sharing your knowledge. And we'll see you around the bend.
Thanks, everyone. Have a good weekend. Bye.
Thank you. Bye-bye.